Okay, everyone, we're live. Good evening, everyone. Welcome to the 10th chapter in this second series of masterclasses brought to you by the Academic Council of IASO. I welcome our past president, Dr. Sanjay Sharma, to kindly open today's proceedings. You're muted, sir.
Oh, sorry. Good evening, everybody. Thank you very much for giving me this opportunity to say hello and at least listen to your masterclass and exams. And I must congratulate Dr. Subbu and entire IASO managing committee, academic committee to have conducted this. And I'm telling you, during this so-called COVID era, the webinars and the continuation of this teaching and education program plus mock exams, which we used to take earlier live, now and virtual, has continued, and I think developed interest in the youngsters to participate. And just now, as I mentioned, it is becoming more multidisciplinary, which is normally we do in our institutions. So the today's topic is a gastrointestinal tumor, stromal tumor. These are actually mesenchymal tumors and normally occurs in most of the time in upper stomach, intestine and other bodies. So for that, I would hand over the mic to Dr. Who's moderating? Viraj.
Yeah.
I think Viraj from Medical College, Medical Oncology from SCG Ahmedabad, along with other people to take over and do the needful. Thank you very much.
Thank you so much, sir. Before we do request Dr. Viraj, we'll just like to give a short introduction of who we have today as faculty. We have with us Dr. Manas Roy, who's a senior consultant in the GI HPB surgical unit at Tata Medical Center at Kolkata. He's also an international surgical advisor to the Royal College of Surgeons at Edinburgh. He's been joined by Dr. Anant Ramaswamy, who's a professor in the Department of Medical Oncology at Tata Memorial Hospital, Mumbai. And he's have had competitive grants from the Terry Fox Foundation ICON, and he has done more than 100 publications, and he has special interests in GI cancers, geriatric oncology, and investigator-initiated studies. The moderator for today would be Dr. Viraj Lavangia, who's the director of the GI subspecialty at HCG Cancer Center, Ahmedabad. We welcome all our three examiners and request them to enlighten all our students, both live as well as who are viewing this in the future on YouTube. The examinees for today are Dr. Supriyo Majumdar, who's a resident in the Department of Surgical Oncology at Guwahati Medical College. And he's being joined by Dr. Sunil, who's a resident at the Department of Surgical Oncology at AIIMS, Rishikesh. A few instructions for the session for our examiners and the moderator. In interest of the online viewers, both live as well as in the future, we request you to give the expected answers to the questions that are incorrectly answered or remain unanswered. For our examinees, we expect you to give to-the-point answers, and you can just pass the buck here to the other, your colleague, which is unlike in an exam. What this does is it saves us time and it maintains the flow of this webinar. And keep catching those hints that our examiners have the habit of, throwing out there for you. For the participants, we do see some senior ISO members who have logged in. We thank you for logging in, participating in this live. And we request you to post in your inputs as well in the chat box. The residents who are online, especially live, this is a unique opportunity to clear all your doubts, theoretical as well as practical, in the next 2 hours or so. That said, now I request Dr. Viraj to take over the first session, which would be the mock clinical examination. And we'll be having 60 minutes for it. I'll be reminding the examiners and moderator at 45 minutes and at the completion to remind them of the time. So please keep looking into the chat box for that. Thank you so much.
Thank you, everyone. Good evening, everyone. Special thanks to IASO and Dr. T.S. Rao, sir. It's a great opportunity for me to be here. And I welcome Anant, my very good friend, and Dr. Roy sir from Kolkata to examine two bright surgical candidates. So for next 1 hour, we have three clinical cases, not necessarily 20 minutes each. So Dr. Supriyo and Sunil, basically you will be asked questions on clinical exam, history taking, and then of course various aspects of GIST, which is operation, surgical related questions, molecular profiling, adjuvant, neoadjuvant. And if you like, we'll also ask you metastatic treatment as well. All right, so feel free to answer whatever you can. So without wasting much time, we'll start with the first case. Next line. Okay, so this is these are short case descriptions, and the examiners will ask you questions about what further information or investigations you would like. So young man, 47-year-old male, IT professional, presented with 3 months history of weight loss and vague epigastric discomfort. On examination, the whole entire abdomen is palpable with a large mass. It is a painless mass. There is no specific hepatosplenomegaly. There is no organomegaly. Rest of the systemic exam was normal. And on general examination, the performance status is well maintained, PS1, and the patient has a pallor. The patient has a long-standing diabetes and hypertension. So with this, I invite my co-examiners. Do we want to ask our students any particular question? What comes to their mind when they see the entire abdomen filled with a mass? Dr. Roy, you want to come in?
Manasa, you're muted.
Yes. Supriyo, what else would you like to examine?
Examination, sir.
Yes. Huge mass in the abdomen. Is there any other part of the body you would like to examine?
I would also like to do a per-rectal examination, sir.
Before that, any superficial examination?
I would like to determine the dimensions, possibly whether it is a superficial mass or it is an intraperitoneal mass or a retroperitoneal mass. I would like to palpate the liver and spleen if it is separately palpable. I would like to check for any pulsations which may be arising from the mass or any transmitted pulsations.
Dr. Supriya, Dr. Manas is asking you a specific question. Think outside the abdomen.
Since the whole tummy is filled with a big mass,
Yeah.
you know, it's
Think
very
outside.
difficult to distinguish between the mass from the liver or the spleen, you know, and you can't say whether it's in retroperitoneal or whatever. Any other part of the body?
Think a little outside the abdomen. Yeah. And
the
don't
genital,
think of this-
external.
Don't think of this as a
genitalia.
gist. Think of this as an abdominal mass. And you know, what else would you like to examine? General physical examination should cover this.
External genitalia examination.
That's okay. You could suspect a
Okay.
testicular tumor with, a large lymph node, but abdominal mass, would you like to examine the neck, Supriyo?
Yes, sir. It can cause engorgement of the neck veins due to compressive symptoms of the on the IVC.
IVC compression will give rise to venous engorgement in the lower limbs.
Dr. Sunil, would you like to add on?
Yes, sir. I would like to look for signs of generalized lymphadenopathy, especially the cervical lymph nodes. I would like to examine.
Excellent. That's fantastic. So you should look for the lymph nodes in the neck, axilla, and genitalia. And
Genitalia.
to finish the exams, you will do a rectal examination.
Rectal examination.
And you should also examine the lower limb for any edema or engorged veins, right?
Yes.
Good. Anything else, Anand, you would like to add?
No, sir. I think assuming all that is negative, can you give us 3 to 4 DDs for this, Dr. Supriya? assuming this is not GIST, okay? Let's get to that. Just say that we don't know it's a GIST masterclass, and this patient comes to you in the OPD, and you know what's your DD?
It can be a benign or a malignant tumor originating in the abdomen. It can be a retroperitoneal sarcoma.
So I agree with both what you said, but let's go from common to uncommon. No? So RP sarcoma, yes, maybe. What else?
It can be a metastatic disease from
okay.
Dr. Sunil, want to add?
Sir, being it a generalized abdominal mass, I would like to think in terms of peritoneal carcinomatosis, maybe mucinous adenocarcinoma, which is formed a diffuse mass, a peritoneal carcinomatosis, and retroperitoneal lymphadenopathy from primary in testis, or lymphoma.
Lymphoma, exactly.
I think those 5 covered it. Yeah.
So supposing, if I may interrupt, supposing if you're suspecting a lymphoma in the history, would you like to ask some other features? So
history-wise, I would like to ask for the B symptoms like fever and.
Well done, well done. Good, good. Well done.
Okay. Sir, Manisha, anything else that you'd want to this one?
I think just to summarize, you would look for the neck nodes, axillary nodes, the venous engorgement, scrotum, and the rectal examination. And in addition to that, weight loss, loss of appetite, fever, night sweat, etc. So how would you like to progress with investigations?
Sir, I would like to get a cross-sectional imaging of the abdomen and thorax.
Okay, so what would you answer? I mean, don't say cross-sectional imaging is very nebulous, very vague.
Yeah.
So be specific. I will do this, not I can.
I will do a contrast enhanced CT scan of the thorax and abdomen.
Abdomen, good, excellent. In addition to that, routine blood test, right?
Routine blood test.
Excellent. So should we have the next slide?
Let's have the next slide. Yeah. So, Dr. Supriyo, these are the images of CT scan, and there is an endoscopic image as well. The patient's hemoglobin was 9. So you want to describe in short what are these CT scans showing?
Sir, on the contrast and CT scan, on the coronal section, there appears to be a proliferative growth, probably arising from the greater curvature of the stomach, which is filling the entire abdominal cavity and displacing other organs, and almost extending up to the level of the lumbar vertebrae, to the left kidney, which is heterogeneously enhancing, with not very smooth on the borders don't appear to be very smooth on the CT scan imaging.
You mentioned something about heterogeneous appearance. What do you make of it? Is it a bleeding tumor, vascular tumor? What is it?
Because of the massive size, there may be some necrosis in the tumor or hemorrhage within the tumor, within the growth.
Can you make that out on imaging?
Necrosis may suggest that necrosis may show heterogeneous enhancements.
Hemorrhage will have hypodensity, right?
Yes. Okay.
So if the hypodensity is also there in the non-contrast part, then you can say that probably that part of the tumor is bleeding. Dr. Sunil, you want to take, what is this seen on the endoscopic image?
Sir, endoscopy, I can see it is...
may I interrupt once again? Anand, may I interrupt? Now, the previous examinee said that he thinks the mass is arising from the greater curvature of the stomach. which is such a huge mass, it may be difficult to say exactly where it is arising from. So in the exam, just say it's a huge mass. It's difficult to say from which organ it is. Don't assume the diagnosis just because we are discussing GIST. Okay.
Completely agree, because here you can just see a mass which is actually pushing the stomach upwards. You cannot see the origin from here. So, just stick to it occupying almost all compartments of the abdomen and pushing most structures upwards and sideways here. Other than that, you can't make out the epicenter.
Now, once again, for the trainees on the YouTube, see the white areas in the mass. These are vascular, and look at the CT scan. The aorta is white, right? Basically, the arterial phase. So whatever is well perfused by the blood comes white. And in between the gray areas are the necrosed area, which does not have a good blood supply. Okay? Proceed.
So Dr. Sunil, can you comment on this endoscopic image?
So endoscopy, I can see it's a submucosal bulge which is seen with the overlying. There is no ulceration or any active bleeding, and the mucosa looks intact.
What do you think is the cause of anemia here?
Anemia, this picture which shows there is no active bleeding, there is no site of hemorrhage or bleeding in this. But since it's a huge abdominal mass and there are a lot of, I think there is indistinct fat planes with the other parts of intestine also. So in this particular endoscopic image, there is no, can be a bleed in the retroperitoneum also, the huge, because of the size of the mass.
Okay, I'll just add on to what Viraj said. Give me 3 causes of potentially of this patient having a low hemoglobin. So one thing you said, the tumor is not bleeding. That I agree. Give me 3 causes. And 1 or 2 you've already given.
So, one is the nutritional anemia because of
correct. Yes.
Nutritional anemia because he has loss of appetite and there is also loss of weight. And
so the easy answer to that is nutritional anemia of chronic disease, because he's been having it for a while now. And the other thing that you said, it has a loss of fat planes with multiple structures in the GI tract. So any of these could lead to bleeding, not necessarily a bleeding tumor, right? So that's what you need to say.
Another important history point of melena is something which we have to ask, which can easily tell us whether the tumor is bleeding or not. Right. So how do you want to proceed? This is the imaging. Patient comes to you with this in OPD. How do you want to proceed, Dr. Supriyo?
I would like to get a tissue biopsy of the lesion, of the tumor. So preferably a core biopsy.
From where?
So on endoscopy, since it looks like a submucosal something which is coming from below the mucosa, so I would like to do an endoscopic guided core biopsy from the submucosal mass.
EUS guided, you
mean? EUS guided, endoscopic ultrasound guided biopsy.
Such a big mass, can we do percutaneous biopsy? Like if you hit anywhere, you will get the tissue.
Percutaneous biopsy can be done, sir, since it is a huge mass and
this is, usual teaching would be that since it's a gastric tumor, you would do an EUS or endoscopic, but this will be palpable. So what Dr. Viraj is trying to say is that you just have to put the biopsy needle and you'll get tissue. That's what he's saying, right? We could go forward probably, Viraj.
Yeah. So now basically we have questions coming here. So of how you proceed. So let's say in biopsy, what do you expect in this patient? So Dr. Ananta asked, with this imaging and this history profile, now can you tell us the differential diagnosis?
May I interrupt here?
Yes, sir.
Now, we know that this patient has a GIST, right? Now, which biopsy would you prefer, USFNA or a percutaneous transabdominal? For this patient.
For this.
Sir, if feasible, should always be US guided, because there has been controversies regarding percutaneous biopsy, though it has not proven any inferior. There was concerns that it would cause peritoneal seeding and cause episodes of chances of bleeding are there.
Right.
So that is proven wrong. So whenever it's possible, US guided is preferred, but percutaneous can also be done.
Right. Okay. Next, ISC.
So what IHC are we expecting, Dr. Sunil?
So ISC, the most common would be CD1174, which is for KIT, which is positive in most number of up to 95% of the patients. And another is DOG1, which is also seen in almost 95% of the patients.
Now, when you do a EUS FNA, do you think the material is sufficient to do ISC?
Sir, US FNB can be done as a core biopsy, of course.
Yeah, that's fine. But why is FNB is not that popular or common?
FNB because of the risk of perforation and bleeding.
It's very expensive. Okay. So I'm asking a general question. From the FNA, if the sample is good, if it is cellular smear,
yes,
can you do an ISC?
Yes, sir.
Yes, correct. But do you know how they do it? This is a general question, you know.
They prepare a cell block and
excellent. They prepare a cell block. Okay.
And send for ISC.
Yeah, that's it. And then they do sections and then that's it. Good. Well done. Move on.
Anything other than a C-kit and DOG1 that you would like, Dr. Sunil, or is that enough for you to say, okay, this is a gist?
Sir, C-kit, DOG1, and the C-kit can be positive in other cases also, but DOG1 is more specific for a gist. And
can you give me 3-4 tumors where a C-kit will also be positive other than a gist?
Sir, it can be positive in leiomyomas and Ewing's and childhood neuro Ewing's and
yeah, you said it. Ewing's can be positive, correct?
And
yeah. So Ewing's, seminoma, leiomyoma, all these can be C-kit positive. So good.
You know the full form of DOG1, DOG. What does it stand for?
Discovered on GIST.
Discovered on GIST.
My God, excellent.
That's like a gold medal question. So you asked it too early.
Right.
Good one. Okay. Good. So we now know it's GIST. The patient is in front.
Just one small question for Dr. Supriyo. Dr. Supriyo, biopsy says poorly differentiated neoplasm. Okay. Now, can you tell me a quick algorithm? How would we do IHCs? We don't do 10 IHCs on day one, right? So how do we do it? The pathologist says it's poorly differentiated neoplasm.
The things I would like to rule out or consider in this diagnosis are a lymphoma panel, a sarcoma panel.
So can you tell me what all things you'll tell the pathologist that I want 1, 2, 3, 4 markers? Okay. So basically, this is a question regarding cup, right? Malignancy of unknown origin. Okay. So probably we are digressing. Anand, what do you think?
Yeah. So just remember this, that what you said is exactly right. You need a sarcoma look, you need a lymphoma look, you need an epithelial look. Okay. So quickly, it should be A1, A3, CD20, Vimentin, Desmond. Okay. At least this much you should say. And the rest you say, you know, boss is the pathologist job. But at least epithelial, sarcoma, lymphoma, that much you should have a basic idea. Okay. But yeah. Okay, so what do you want to do next, Dr. Supriyo? We've got all our baseline investigation done. We've agreed that this is a GIST. The patient is fit and fine. What do you want to do?
I would like to do a molecular studies for genetic mutations of this tumor, since I would not be considering an upfront resection for this tumor, and probably neoadjuvant therapy may be required. So I would like to have a genetic testing of this patient.
Why would you not consider upfront surgery?
So considering it is such a big mass and which is infiltrating probably into other structures, so the surgical resection might be very morbid. So neoadjuvant therapy has been, if it is a GIST and which is responsive to the it is certain mutation positive, then it can, it has good response to neoadjuvant therapy, which can reduce the morbidity after a surgical resection. So it may give a chance for a relatively less morbid procedure. So I would like to do a molecular. I would like to not do upfront surgery for this patient.
Maybe Dr. Manas can, expand on that.
Well, Anand's friend is a medical oncologist in a hospital. And what he tells me that for metastatic settings only they do molecular studies. Primary resistance to imatinib is extremely uncommon. Am I correct, Anand?
Yes. I just want to know whether you would agree that we give neoadjuvant first. And
yes, of course. It's a huge tumor.
Yeah, it's a huge tumor.
So we have to.
Yeah, agree. So, Dr. Shupriya, you said that you will do molecular studies. And as Dr. Manas said that, this is not metastatic and primary resistance is rare. So why do you want to do it?
Because there are some some rare GISTs which are not sensitive to imatinib therapy. And if we empirically start and that tumor, it will progress and it will further delay the definitive treatment of surgery. So I would like to know whether the imatinib will be, the neoadjuvant therapy will work. And for that, I would like to know the molecular genetic testing of this patient.
Okay, that's kind of right. Dr. Sunil, would you like to expand on that? What particular mutations are we looking at?
You are muted.
Dr. Sunil, you're muted.
Hello, sir.
Yeah.
We would like, primarily, I would like to look for KIT and PDGFR mutations. And again, with in the KIT, I'd like to know whether it's exon 11 or exon 9. Because it, again, the dose of the imatinib differs based on whether it's exon 9 or 11.
Excellent. Yeah. So what we normally do in clinical practice is start the patient on 400, and then once the results come in, maybe modified dose, right? Because predominantly you're going to see exon 11 mutants. Great. How long would you want to give this imatinib? I mean, you're a surgeon, you want to get in and cut. So how long will you give it?
Sir, imatinib, if you are starting empirically, we would like to know whether it's responding to the disease. So we'd like to get an imaging as early as 2 to 4 weeks. And if it is responding, the neoadjuvant recommended is up to 6 to 12 months.
4 weeks is a little early. You need to give at least 8 to 12 weeks. Okay.
3 months.
Yeah, 3 months, as Sir said. So 2 to 4, you will see a response, right? But that's not going to help you. I knew you would say PET CT. It will show a response as early as 1 week. I agree with that. But, in terms of reducing the size of the tumor to, the reasons that you mentioned, morbid surgery and all that, at least 3 months. Okay. But yeah. So you've given it any further slides on this, Viraj?
No. So a question to Dr. Sunil, how do we order these molecular studies? Like what is the test we write on prescription pad?
So
c-KIT and PDGFR by what? IHC?
No, sir. NGS.
By NGS?
Yes.
And Dr.
Any other method?
Any other method?
For the mango people of the world who don't have access to NGS, any other method? What he said is right, by the way, but you don't always need an NGS.
PCR.
All right.
Yeah.
Excellent. Yeah.
And by the way, why does the size decrease? Gastric GIST. Why does it decrease on imatinib? And if you have a huge liver met responding to the imatinib, but the size doesn't decrease.
This goes back to what we had discussed earlier when we were discussing the CT.
And the low hemoglobin.
Yeah.
Degeneration of the tumor.
It's connected to the GI tract, so. Okay, carry on then. So after 3 months, you would re-image and then
If the disease is operable without necessitating multi-organ resection, so the choice would be surgery.
Good. So basically organ preservation, right?
Organ preservation, yes.
Excellent. Any particular principles of surgery?
So the surgery, the goal should be to achieve R0 resection macroscopically.
Okay.
Without necessitating multi-organ resection, multivisual resection.
How about lymph nodes?
So lymph node, lymphadenectomy is not recommended.
Not recommended. Good. Yes. Good. Excellent. Okay.
And if I went in and found that the lymph nodes were enlarged, then
the gross lymph node resection, the lymph nodes have to be removed. The grossly enlarged lymph nodes have to be removed.
Good.
And Dr. Supriyo, you think you'll be able to salvage the stomach, or it will be total gastrectomy? What do you think?
Based on this imaging, sir.
And after 6 months, the medical oncologist imatinib shrinks it to more than half.
It may be possible to preserve some function, some stomach, some portion of the stomach. But if the response is not that good, if it is not possible, then a total gastrectomy may be required.
So what's the margin? I'm trying to ask, what's the margin you would at least want?
On gross 1 to 2 centimeter of gross resection margin should be the aim, with the aim of achieving microscopic negative margins.
Excellent.
Now, Sunil and Supriyo, have you seen such a patient before? Have you actually treated?
So not of this, sir.
See, even after neoadjuvant treatment, they often look very horrible. But when you actually open the tummy, it may be just a small portion of the tumor may be actually attached to the stomach, So don't get scared. Okay, don't get scared. That's my message to you.
Viraj, can we go on to the next one?
Let's go to the next case.
Good job, both of you. I think both of you did a good job here.
Very well done. So now, slightly twisting the case, an elderly person, 78-year-old, lives, he and his wife.
Can I stop you? Can I stop you for a minute?
Yes, sir.
In the first case, supposing you managed to do a large wedge resection or something like a bariatric surgery, what have you. But after 2 weeks, when the patient comes back to the OPD, one of the margin is positive. What will you do?
Sir, for a microscopic,
it's a microscopic margin positive. Then
there have been studies which have showed that R1 resection, that microscopically positive margins, is not associated with any worse outcomes compared to inferior outcomes compared to R0 resection. So further re-resection for microscopic margins is not generally advised, since post-operatively adjuvant therapy will be given. But it may be have to be individualized depending upon the patient.
Excellent. So R1 resection is not too bad, right? Now, supposing this patient has a low risk GIST, okay? And if it is a microscopic positive margin, would you give adjuvant imatinib?
Low risk
GIST, margin positive. You don't want to go back, which is absolutely brilliant answer. But then R1, will you consider adjuvant imatinib?
If the patient has low risk for recurrence, then I would not consider.
Excellent. So R1 ignore. Okay. Carry on, Viraj.
Okay. So in this case, we will be mainly discussing about the role of operation and adjuvant data. So this is a 78-year-old male, lives with his wife, again presented with melena for just 1 week duration. No history of any fresh bleeding at anywhere. No history of any abdominal pain or vomiting or any signs of obstruction. But on asking, patient has postprandial episodic colicky pain relieved by passing of the stool. There is no history of weight loss, perfectly well maintained, no comorbid conditions. On exam, there is a mobile and palpable periumbilical mass, no organomegaly, no dilated veins. Rest of the exam is normal. And again, this patient has pallor and performance status well maintained. So with quickly, without wasting much time. Any quick DDs on this examination? Palpable mobile periumbilical mass in a 78-year-old, perfectly healthy individual. Dr. Supriyo and then Dr. Sunil.
Sir, periumbilical mass, which is mobile, can be a mesenteric cyst
In this patient,
arising from the root of mesentery, and any small bowel tumor. Small bowel tumor is one of the DDs.
Dr. Supriya, anything else that you'd like to add? I agree with the large mesenteric cyst, small bowel tumor. Anything else?
It can be a benign tumor of the, it can be a leiomyoma or leiomyosarcoma of the small bowel.
I think after the first two DBs, we were stretching because even I couldn't think of too much. Dr. Manas?
I mean, theoretically, it could be a small bowel tumor with some,
Okay, let's go to imaging.
Yeah.
Let's go to imaging. Next slide. All right. So, Dr. Supriya, you want to take this? By the way, this patient we just operated last month. So,
on the CT scan, there it shows.
So you can see the tumor, right?
Yes, sir, I can see that.
So on the first image, above the kidney, you can see the starting.
Yes, sir. Yes, sir.
And subsequently, it's getting large, and at the bottom, it is getting bilobed. So, right? So where do you think it is arising from?
It is probably arising from a small bowel loop, from jejunum or ileum, sir. Ileum.
Ileum. Jejunum, right? Ileum.
Jejunum, sir.
Right.
Jejunum, sir. Yes.
Right. Excellent. So, Dr. Sunil, now this is the patient. How do you want to approach?
He's a symptomatic patient with, again, since we are discussing GIST, and this looks operable.
We don't know this is GIST, right? You want to know whether this is GIST before operation?
Yes, sir. Imaging wise, I think it is heterogeneous enhancing lesion adjacent to the jejunal loops.
It could be.
And
I think, Dr. Sunil, in the exam, I would say that, I mean, and Dr. Manas can correct me here, you can say that appears to be an operable small bowel tumor and leave it at that. Dr. Manas, maybe you can correct me.
Yeah, absolutely. See, we do biopsy only if it changes the management. You know? Otherwise, no point. If you think it's a lymphoma, you won't operate. If you think it is tuberculosis, you won't operate, you know. And just the transverse coronal, you know, you have to go for the actually on the console, discuss with the radiologist, have a look at the sagittal coronal, you know, reconstructions, and if it is operable, you best to put the knife first, you know.
Yeah. Go ahead, Dr. Sunil. Sorry. Yeah.
Sir, it looks like operable small bowel tumor. So if it is operable, then I would directly go for surgery in this patient.
You think it is operable?
Yes, sir.
Okay, you want to do diagnostic lab or straight away go in?
Clinically, the mass. So excuse me. Clinically, the mass was mobile. You know, that's a good sign for the surgeon. Okay.
Right. So, Dr. Sunil, straight away go in or do?
No, sir. I would like to do a diagnostic lab, rule out any peritoneal or liver deposits, and look at the operability then.
Dr. Supriyo, do you do for small bowel tumors, which is more of sarcomatoid origin? Do we do diagnostic lab?
We don't routinely do diagnostic lab for small bowel tumors. Usually.
So maybe, I think again, Dr. Manas can correct us here, but I think the question was loaded, Dr. Sunil. You normally don't you will look at peritoneal surfaces, you will look at the liver and all that, but technically it would not be called a diagnostic lab. You would go in, look at all the surfaces and cut if you can cut. So we usually don't do a diagnostic lab. Okay, so beware of examiners like that.
And you know, it's a semantic. Should you call it a diagnostic lab or staging laparoscopy? Staging is more appropriate.
Staging is
correct. So these are all trick questions. Correct. So Dr. Sunil, can we take this out with a minimal invasive approach?
Sir, there is no much of prospective data on minimal invasive surgery in GIST. So if you can achieve
you're not proven this is GIST.
Okay, sorry. Operable is
78.
Yes, sir. Right.
Dr. Supriyo?
Sir, if the patient does not have any comorbidities, if fit for general anesthesia, it can be done laparoscopically as well.
Okay, what I'm just asking you, what are the I mean, how can the surgeon upstage this tumor?
Correct.
Very difficult question.
By tumor rupture.
Excellent. So that is the first thing. You know, this is not a small tumor, by the way. It may be mobile. It may be small, but it's by no means of imagination. It's a small tumor.
Right.
You know. So and the last thing that you would like to do is to rupture the tumor. Okay.
So very few tumors where minimal invasive is not actually this is where you straight away just open it up and remove it.
That's it. Straight cut and finished. Good. Next.
Right. So once we have operated this tumor, I'll tell you a hypothetical condition. Patient has a 10 centimeter tumor with mitosis of 10 over 10 HPF, 50 HPF, and it's arising from the jejunum. So what's the next step?
So there are 3 high-risk factors for this patient, sir. Size of 10 centimeter, mitotic count is high, it is more than 5 per 50 HPF, and also it is a non-gastric location. So all 3 favor a high-risk GIST. So adjuvant imatinib will be required for this patient.
What risk stratification did you use?
Modified NIH criteria, sir.
That was a very good answer, and it's very logical answer, Dr. Supriyo. 5 non-stomach. Just remember that. Largely, you would then give adjuvant. There are nitty-gritties, but you know, more than five non-stomach. Think adjuvant. Good answer. And how long would you give the adjuvant imatinib?
So based on the data from the SSG 18 trial, 3 years minimum.
Never say, don't say data. Just say 3 years if the examiner asks you, because then they'll go into trials and you can get stuck. So how long will you give it?
For a minimum of 3 years, sir.
Why did you say minimum?
Sir, because
it is 3 years, okay? Just say 3 years, and then you have the IASO trial, which said 3 is better than 1, and there is ongoing data for a 5 years, but the standard still is 3 years. That's the way you would answer. Okay.
So, Dr. Sunil, would we do molecular studies for adjuvant treatment?
Sir, adjuvant treatment, yes, sir.
Give us 3 reasons why.
So again, like I told again, even if it is c-kit, we would like to know whether it's 11 or 9, and some up to 15 to 30% patients are not c-kit, they are PDGFRA. And again, one particular type of PDGFRA is not sensible to imatinib. So I would like to still do the molecular testing.
Good answer. Good one. Yeah.
Tell something about exon 13 and exon 17 mutation. What if the patient has exon 13 or exon 17? Can they have?
Yes, sir, they can have exon 13 and 17 as well.
How common are they? Are they the primary mutation of the GIST?
No.
No, sir, they're not primary.
No, sir.
usually they develop over time on imaging, right?
Yes, sir. They're only 1 to 3% of the time.
Excellent. Excellent. Great. They're answering like medical oncologists, aren't
Yeah. They're well prepared.
they? Very well prepared. Well,
Supposing it's a low risk tumor and due to your very basho, surgical techniques, you manage to do laparoscopically, and in the process, you rupture the tumor. Then
It becomes high risk. A tumor rupture is a high risk.
High risk and
excellent. Good. Well done.
okay, next slide. So for last 10 minutes, we have slightly twisted. Next slide, please. Slightly twisted the scenario. Okay, so this is a 30. Then this is a real case, and he's one of my very close friends as well. He's a 30-year-old male, works in a hospital, had operation 5 years ago in a remote place for a small bowel tumor, which was GIST, and he had a theft in his house, and there are no records for me to confirm. Okay. On exam, it's completely normal. He just comes for normal visit, and next day I image it. Next slide, please. So on imaging, we found this. So Dr. Supriyo, can you tell me? The left one is CT, the right one is MR. So on CT, what are we finding? Over the left kidney.
Yeah. There is a smooth, well circumscribed mass which is arising at the
Hilum, renal hilum.
yes, renal hilum, near the renal hilum.
And the same thing is corroborated in the MRI. So, Dr. Sunil, would you want to remove this or do a biopsy, or patient is completely fine, just coming for surveillance? Dr. Sunil?
yes, sir.
This was a trick case, so I knew you won't be prepared for this. It's a real case.
Okay, think out of the box. What could be in that location? Just think.
It can be an
Yeah,
adrenal tumor.
something adrenal. Okay, a little unlikely because, as Viraj will point out later. Anything else? He has a history of surgery before. Remember that. Does that strike a bell? Does that help?
It can be a recurrence of the previous tumor. Recurrence.
What tumor could that be?
Sir, can it be angiomyolipoma?
Will not present with this CT.
If the patient has a previous history of surgery, which the biopsy of which the final histopath of which showed GIST, so it can be a recurrent GIST.
Okay, recurrent GIST. Something else which is also a slow-growing, benignish thing.
How would you approach? Are you tempted to put in a needle here or operate, or you want to just leave it alone? Yes. Dr. Rajkumar Patel. Very well. Very nice. So somebody suggested something in the chat. Nice.
Okay, so will you do a biopsy or not, Dr. Supriyo? Simple.
How will you proceed?
Yeah.
Or you will say, come after 6 months, we'll scan you again.
Either of you can take that. Either of you.
Sir, we'd like to do the biopsy and confirm
Biopsy.
Yeah. When in doubt, put a needle. I mean, that should be the dictum. Okay. There's a tumor. You don't know what its biology is. You don't know what its space is. You know nothing other than the fact that it's there. Put a needle, sort it out. Unless you're going to resect it.
So there is a line in Bailey's, right? When in doubt, take it out. And the medical oncologists we have, when in doubt, don't. It's completely the opposite. So yeah, this is a biopsyable lesion, and we did a biopsy, and the biopsy came out to be mesenteric fibromatosis. So now, so probably he had earlier mesenteric fibromatosis. So have you encountered any mesenteric fibromatosis in your practice, Dr. Supriyo or Dr.
No,
Sunil?
No.
Have you heard of it or have you read about it?
Yes,
We have heard about it.
So can Dr. Sunil, can you enlighten us what is that? You want to remove it or not?
Yeah, yes, sir. If it is operable, yes.
Okay. Would you like to rephrase or rethink that?
It is causing problem then.
Remember that he had it before and it's come back, likely in the same location. Do you still want to go in and remove?
No, sir.
Nice. Yeah. So what I suggest is it's not a very common topic. You can read the 2020, I think it's the ESMO guidelines. It's a very crisp set of 5-6 pages. So what was initially operable and operated, people are far more conservative now. Okay. You generally either observe them, and these guys can do well on observation for anywhere up to 2 years. If you want to treat and they're symptomatic, you can consider tyrosine kinase inhibitors. There's actually phase 3 data for sorafenib. So, it's more conservative than, boom, boom, go in and remove, because they tend to come back. Okay. Do you know what IHCs come positive on this? Any idea?
PDGFRA?
I don't think. No, I don't think. I could go and check, but I don't think so.
No, Hallmark IHC.
Hallmark, I mean the one which will say that this is a desmoid.
Desmoid. HMB 45.
That's melanoma.
No, exactly.
Desmoid is correct.
Okay, just mark this up for an exam point of view. It's the SMA and the nuclear beta catenae.
SMA.
Okay, yeah. Okay, just remember that, and more than that, you should not be asked. So, yeah. Dr. Manas, anything?
So these tumors are very difficult to remove, and get a proper arterial resection. It's very frustrating.
So, Dr. Sunil and Dr. Supriyo, any genetic condition or hereditary disorder where you find these tumors? Mesenteric fibromatosis or desmoids?
Primary familial
Right?
primary familial GIST syndrome.
Okay, the first 2 alphabets were right. Would you like to modify the next 2?
Yes.
Familial adenomatosis?
Adenomatosis.
Okay.
Yeah.
Polyposis, FAP.
Yeah.
Polyposis.
FAP and Gardner. So usually when you have a FAP patient, when you operate them for hemicolectomies or total colectomies, they develop these tumors, desmoid tumors, because they have high tendency and they cause a lot of problems. So like Dr. Anand said, we can use either TKI or very well controlled by liposomal doxorubicin. All right, so something important. So this patient had 200 polyps in the colon. Again, we didn't know, we just put a scope and we found small 1 millimeter to 2 millimeter polyps in his colon as well as stomach. So this patient has Gardner syndrome, and actually he never had GIST. For academic purpose, I could get the slides back and it was all mesenteric fibromatosis all over. Nice. Very nice, very well answered, both of you, Dr. Supriyo and Dr. Sunil. Dr. Manas sir, you want to put some final comments before we hand over to Anand?
I learned a lot. No, I think the boys have done extremely well. They're up to mark, and I think they read a lot these days. Excellent, well done.
Very well.
So if you did a very good job, must say. Yeah, well done.
Thank you.
I'll just tell you, Dr. Supriyo and Sunil, I was concerned that since GIST is predominantly, we were going to ask you molecular. Ask one of the senior doctors that should we ask you such questions, and they said, please go away. They oncologists first and then surgeons. Yeah. And you have proven that. Very well done. Job well done.
Good
job.
Thank you.
Thank you.
Thank you. Thank you so much, Dr. Viraj, Dr. Anand, and Manas sir. Well done candidates. And that brings us to the next part of this webinar, which would be the expert talk by Dr. Anand Ramaswamy. While he loads his screen, we request Dr. Viraj and Dr. Manas Roy to please wait till the end because we'll have a short Q&A session with all three of you. Over to you, Dr. Anant. You may share your screen.
Yeah, thanks. Thank you.
So Anand, we'll have to show something very difficult. They've learned the majority of the stuff.
No, yeah, it's going to be a complete repetition of what we discussed, which is sad to say. But yeah, I didn't know they would be this well prepared. This is very good. Just one sec while I share my screen. Yeah, is my screen visible?
Yes.
Okay, great. So I know it's closing in on dinner time, so I'll try and wrap up in around 20 minutes. There are not many controversies in GIS. Largely, treatment is fairly linear, but I'll try and cover some points from a general point of view. So these are the few things that I'll cover: the basic epidemiology, adjuvant, neoadjuvant, and advanced GIST. We know it's a rare malignancy. Western data, the SEER registry says that it's, the incidence is only 6.8 per million, and it's very rarely hereditary. Western data says that the age is around 60 to 65 years. The commonest, as we know, is from the stomach. 60% is stomach, and then it's a small intestine GIS. Very rarely you have colonic, rectal, and mesenteric GIS. This is data collated from India, and I think it's important we know that. In India, from the series available, GIST appears a decade earlier. It's around, the median age is around 50. And most of our tumors are larger. They are high risk as compared to the West. In the West, you have a lot more smaller tumors. In India, you probably have later presentations and larger tumors. The commonest site still remains stomach, followed by small intestine. It can be incidental. We occasionally pick up incidental GIS on an upper GI scopy, but we predominantly see symptomatic patients, and the most common symptoms are pain and GI hemorrhage, along with an abdominal mass. This is the standard guidelines for how you work up a patient. Less than 2 centimeters GIS, which are seen on endoscopy, you can do an EUS and follow them up with surveillance. Anything more than that, you need to evaluate either with a biopsy or a surgical exploration if it is not advanced disease. These are the investigations that you commonly use. These are well known. The only point is that a CT, a contrast enhanced CT of the abdomen pelvis, is good enough. You could do a PET CT or a PET CT in case you're planning neoadjuvant, because you can get an idea of the biology of the disease when you give neoadjuvant imatinib. This is just the initial papers which say that size is not everything with GIST. You can have the same size, but you can have excellent responses if there's a change in the tumor density. And this is what led to the Choi criteria. In fact, if you start a patient on imatinib in metastatic or locoregionally advanced GIST, you can see responses metabolically in as early as 4 days. But we normally do a response assessment after close to 2 or 3 months. They're usually 5 to 8 centimeters. Morphology has become less and less important now because we usually confirm with IHC. Previously, we used to have different microscopies, but currently not as important. As I mentioned earlier, some of the common c-KIT positive tumors are melanomas, angiosarcomas, Ewing's, and seminomas. DOG1 detected on GIST is commonly seen along with c-KIT positivity, and it is also one of the confirmatory markers when you have c-KIT negative tumors. And a combination of c-KIT and PDGFRA is almost 98% diagnostic of a GIST. It's very rare to have a c-KIT negative and DOG1 negative GIST. These are some of the other markers that are also seen on GIST, purely of academic interest. So what is the c-KIT? So this is a structure of the c-KIT receptors and the PDGFRA receptors. So as you can see here, the exon 9 and exon 11 are juxtamembrane. This is the membrane, this is external, this is internal. So these are juxtamembrane parts of the c-KIT receptor complex, and mutations in these are what drive GIST. So this particular receptor mechanism is the key to the entire etiopathogenesis of GIST. You have activation of this receptor, and mutations in it cause activation without ligand, and that is what leads to GIST. Earlier, when we did not have NGS, approximately 10 to 15% of patients would be c-KIT mutation and PDGFRA mutation wild. But now when you do an NGS, only 1% is actually truly wild. When you do an NGS, you will find reasons like SDH deficiency, BRCA, BRAF, RAS, and NTRK. So only 1 to 2% are truly wild. Almost all the others always have some mutation in them. What is the importance of this in a nutshell? This was answered by the examinees also to a certain extent. If you have an exon 11 mutant, you give imatinib 400. If you have an exon 9 mutant, you consider 800. Exon 13 and 17 usually are post-imatinib when a patient develops resistance. A PDGFRA exon 18D842V is a specific mutation resistant to imatinib. If you have an operated patient with this mutation, you will only observe, not give them adjuvant imatinib. Childhood GIST have neurofibromatosis 1 and SDH mutations, and NTRK fusions are also seen in GIST, and you have newer drugs for them now. Risk stratification is important. Again, this was referred to by one of the candidates. There are many classifications. The one that I find most convenient and that's also used commonly is the modified NIH criteria. You don't have to memorize this. Just remember that 5 and 5 are cutoffs. A gastric GIST of 5 centimeters may be intermediate risk as long as the mitotic index is less than 5. Anything else beyond 5 is high risk. That's the way I remember it. There's no use remembering the whole table. It's also important to note that none of the risk stratification include molecular analysis. So, there's something that needs to be done there, but currently none of them use a c-KIT mutation status for stratification. This is what we do in TMH, as it's something that as a guideline that we use. Resected GIST, you operate. Those that are advanced GIST, you treat with TKIs. Those that are not resectable upfront or are difficult to perform surgeries, you consider neoadjuvant imatinib. I'll come back again to this, but this is just a kind of flowchart that we follow at our hospital. So surgical resection is the backbone. I don't have to explain to the surgeons here what you're supposed to do. You all know this very well. From an oncology standpoint, there are only 3 things that are important to me. 1, a gross complete resection. Don't rupture the tumor. Don't do a lymphadenectomy unless required. And 1 to 2 centimeters gross margins is good enough. There are large series from North America would say that as long as you have an R0 or R1, that's fine. R2, of course, is worse, but R0 or R1 is good enough. These are basic survival numbers for patients with localized disease. Resection is possible in almost 85% of patients. 60 to 80% of patients, do well over the long term. 20 to 40 will recur, and the median time to recurrence is anywhere between 18 to 30 months. This is again, the same thing as I had said earlier. Just a quick slide on how imatinib works. You have constitutional signaling of the c-KIT by ATP phosphorylation. What imatinib does is blocks this site, and ATP is you're not able to you're able to prevent further signaling because imatinib is blocking the ligand ATP binding site. So while surgery is the cornerstone, it was seen that approximately 50% of patients in earlier times would recur. And since imatinib was working in the advanced setting, and the first patient who was treated with imatinib actually was an NEJM paper in 2001. Based on the dramatic response, it was published, and then they took it in other scenarios. That so this trial was the first one, IASO Z9001, where high risk patients were either observed or given 1 year of imatinib, and imatinib prolonged recurrence-free survival. There was no difference in overall survival because majority of the patients received imatinib on progression. So once you knew that imatinib worked, how long to give it was the next question, and this was looked at by the SSG AIO trial, where patients with high risk GIST. Now again, the criteria for high risk are slightly different from what we use now, but still they are valid criteria. And they gave 400 for 1 year or 400 for 3 years. Again, there was a difference in recurrence-free survival as well as overall survival. So the current standard for adjuvant imatinib in high risk GIST is 3 years of imatinib, 400. Low risk and ultra low risk, you do not give imatinib. And in intermediate risk, it is a discussion with the patient where you either give or not give. Guidelines are unclear on both. There is some emerging data for 5 years of imatinib in operated high-risk GIST, but we need to wait for further evidence. But the survivals look good. You have an OS of 95%. So this may become a standard in the times to come, but still not. Neoadjuvant therapy, it is an emerging concept. It has emerged over the last 7 to 8 years, where difficult to operate tumors are offered neoadjuvant imatinib so that you can operate safer. The key is that anywhere between 4 to 12 months of imatinib is considered good before considering surgery. You can see responses as early as a week, as I said, but at least 4 months of imatinib is what you want. Specific situations, rarely in rectal GIST, when you may want to consider rectal sphincter preservation, large gastric GIST more than 10 centimeters, and those that require multivistral resection. These are the 3 largest data sets where you have considered neoadjuvant imatinib. They are very heterogeneous criteria used for inclusion in these studies, but some of the points are that tumors more than 10 centimeters usually is something where you would consider neoadjuvant imatinib. The key thing is that neoadjuvant imatinib appears safe, and a majority of patients do undergo resections. Very few patients drop out because of neoadjuvant imatinib, and it is well tolerated. I mean, that's the key things that you got to remember when you give neoadjuvant imatinib. So advanced disease, 400 milligram per day is the standard, unless you have specific scenarios like I had mentioned earlier. Multiple phase 2 and phase 3 trials have now shown, and I won't go into details of that, but you should know that imatinib has proven well over time that it's almost a wonder drug when it comes to GIST. And one important thing is that you do not discontinue imatinib in patients with advanced or metastatic GIST. And this is just an elucidation of the same. These were the 3 large studies which showed that, imatinib works very well. Earlier studies said that you would expect approximately 1.5 to 2 years of progression-free survival on imatinib, but newer data sets have said that it could go up to 2.5 to 3 years. So, imatinib does keep the disease in check for a long time. And because of the low response rates, as you can see here with 400 in exon 9 mutants, you consider 800 milligram dosing. Should you interrupt imatinib? No. This was a study from France where they said that if you can see the wide difference in curves, within 7 to 8 months, the patients start progressing, and not all of those patients can be rechallenged with imatinib. So the consensus and the standard should be imatinib till progression. So there should be no doubt on that. In resource constrained settings such as ours, where post imatinib and a second drug, can you rechallenge with imatinib? This has also been seen in a small study. Then you had newer options which are available nowadays. You could rechallenge with 400 or a double dose. It does not help too much. It may control the disease for 2 to 3 months. In this study, it was actually just 1.8 months. So unless you're out of options, re-challenge with imatinib is not a very great idea. So it is important to know that even though imatinib is a tablet, up to 35% of patients are not compliant with imatinib. Just like chronic myeloid leukemia, where 30% of patients actually stop taking the drug, the same thing happens in GIST. So at every visit, you need to ask your patient whether they're compliant. And the reasons are as simple as forgetting to take the drug and, of course, adverse reactions. These are some of the common side effects that you see. Now, it's important to know that if you actually look at the grade 3 and 4 events, it's not much. Most of the side effects are just around 1 to 2%. But if you look at the all grade side effects, and some of these can actually be quite debilitating to patients. Things like muscle cramps, leg edema, facial puffiness. These are common reasons that patients stop imatinib. So it's important to counsel patients that, these are not life-threatening or they're not very important side effects, and you should counsel them to continue the drug as long as these are manageable. So even though the grade 3, 4 events, adverse events are not much, please keep a note of, other adverse events that are common when on imatinib. This one on resistance, usually it's uncommon. If a disease progresses in less than 6 months, then you've got to look for a PDGFRA mutation, or, is it truly a wild type? Secondary mutations are usually due to exon 13 and exon 17 mutations and downregulation of KIT. This is just a summary of the drugs that we now have for imatinib. For patients who have progressed on imatinib, you have sunitinib, regorafenib, pazopanib, ripretinib, and avapritinib. So the recommended options are the first, second, fourth, and fifth. The fourth and fifth drugs are still not available in India, so we usually consider sunitinib on progression and then later regorafenib. This is just a pictorial representation of the same, that you can extend the life of patients who have progressed on imatinib as well, but none of them are as effective as imatinib. Imatinib is very, very effective. So just as a summary, you need to understand the importance of c-KIT and PDGFRA. They are key and central to the pathogenesis of GIST. Consider mutational testing in all patients with GIST. Surgery is key. Neoadjuvant strategies, we're using it more and more in large tumors or for organ preservation. 3 years of adjuvant imatinib is in resected GIST is the standard. In high risk, you will give it. In intermediate risk, it is a discussion with the patient based on a risk-benefit ratio. Imatinib is the mainstay in advanced GIST. Ensure compliance, and that is key. And there are now new available options for GIST. With that, I'd like to wrap up, and thank you for your kind attention.
Thank you so much, Dr. Anand. Now we go on to our last segment, which is Q&A with the experts. And what we have done is we have just clubbed the questions that we see here and on YouTube and rounded them up for our 3 examiners. So I've addressed the questions to particular examiners, but obviously all are welcome to chip in. The first one is, what are the common anatomical indications for neoadjuvant therapy in clinical practice? And posted this to Dr. Viraj and Dr. Roy.
Yeah, so I feel like I am the examinee now, but a very nice question, pertinent question. What I have used in my practice is we had a large rectal tumor, which was a GIST. And we have enough data now for rectum for organ preservation. These are something where neoadjuvant therapy precedes before operation, or we can avoid operation in certain situations and do sphincter preservation. And of course, the large gastric GIST where there is a mutilating surgery, we have enough evidence building up that neoadjuvant strategies are a fair way or a reasonable approach for these type of tumors. Yeah.
Now, Viraj, if I may add, for the rectal GISTs, as most of our patients present rather late, if you operate without the neoadjuvant, will invariably rupture the tumor. Sphincter preservation comes later, you know.
Right.
That is the almost mandatory that we have to give some kind of neoadjuvant for rectal cyst.
Point well taken.
So we'll move on to Dr. Anand. Do you have anything to add, or should
No, completely agree with what both of them said.
Okay. So the next one we have is for Dr. Roy, and it's a surgical questions that which type of gastrectomy do you prefer for proximal gastric cysts, and what is your reconstruction of choice for proximal dissections?
The reason why this question has been asked is, you know, if you have to remove the GE junction by doing a proximal gastrectomy, and this patient, that's because they tend to live long, they have a lot of reflux, you know, esophagitis, and a stenosis of the anastomosis is quite common. It's a horrible, you know, lifestyle, and patient might develop a stricture of the anastomosis. If you do a proximal gastrectomy, they may need multiple endoscopic dilatation, etc. So if push comes to shove and you have to do a proximal gastrectomy, might as well do some sort of a double tract reconstruction. The jejunal loop, you can Google it to know. It's not a very difficult reconstruction. So try to do a double tract reconstruction for a proximal gastric cyst.
Great answer, sir. Thank you so much. The next one we have is leiomyosarcoma of the bowel different than GIST, and how much so?
Okay, so the easy answer is it's like chalk and cheese. They are vastly different tumors in terms of presentation, pathology, treatment. Leiomyosarcoma is generally treated far more like, the sarcoma way than a GIST. You try and operate where possible, and you are trying to achieve an R0, and usually that is enough unless you have a tumor which is more than 5 centimeters or a high grade LMS. And GIST is treated completely differently. You try and operate, and if it's low risk, you observe, and otherwise you give imatinib. But the right from presentation, location, treatment, everything is different. It just used to be confused with leiomyomas prior to the differentiation molecularly, but no relation to LMS at all. Yeah.
And our last question is,
if I can add also for other sarcomas of the bowel, which are not upfront operable, of course, the role of neoadjuvant chemotherapy is also vastly used in majority of centers. That is something different which we can pitch against the GIST. We don't use chemo for GIST.
So our last question for the day is debulking an option for metastatic GIST if resectable? And post that to Dr. Raj.
Yeah. So one of the students did mention that R1 resection. Resection is the key for GIST. Operation is the cure. R1 also is acceptable. We have many times patients coming with like 8 or 10 liver lesions, and patient is completely okay. It is acceptable to at least resect part of the liver, which is causing main problem, and you leave the remaining behind and treat it with the medical management. So yeah, debulking is an option in certain situations.
Dr. Roy, Dr. Anand, any comments on the last?
Yeah, so the answer to that is, if it's causing symptoms, try, remove, give medical management. If it is not causing symptoms and you cannot operate the whole thing, don't go and give only medical management. Is there any prospective data for this? No, and we will not get it. But it's a case-to-case thing, as Viraj had said.
Absolutely. It has to be a la carte, you can't generalize.
Yeah.
So that brings us to the end of this segment as well. I would like to first thank all the 3 examiners here for so patiently going through all the aspects of GIST in the last 1.5 hours, and clearing out, I think, most of the things that a resident needs to know in the field of surgical oncology. Thank you, all the 3 examiners. And with that, I invite our convener of the Academic Council of IASO, Dr. P. Subramanian Rao, my boss, and to my right, to deliver the vote of thanks for today.
the selection of faculty for this was probably the most difficult. And the surgeon was simple because we always wanted Manas to be around. Manas is somebody who is really respected across specialties as a top GI oncologist, very scientific, very skilled, very knowledgeable, and always willing to share. So
Thank you.
many great qualities, very admirable personality. So Manas was selected, and after that, I went on. Sajan, me, and the advisory panel, which includes Sanjay Sharma sir, Sanjay Kapoor, Harit Chaturvedi, and all of them. There were two names which came up. Viraj is somebody I always knew, and I was really pleased to understand what good work Anant does. So they both came in, and I'm not surprised why everybody talks about these two when it comes to GI medical oncology. And we also knew that although surgery, both the medical oncologists have been stressing that surgery is the most important, but there's nothing much that is controversial, and it's all about wide excision or excision. So everything is with medical oncology. So this is the only session where there's only one surgeon and more medical oncologists. And I this is one of those sessions I sat through the session also because I had lots to learn, and I'm very glad I've learned so much today. So thanks to these three gentlemen who have enlightened us, and the students were really good. I was surprised that they were really good. Most of them are medical aspects, but I think as Viraj already said, you are an oncologist first, and then only a surgeon or something else. So I think it's important to learn everything. The academic council thanks the IASO core, specifically Dr. Rajendra Toprani, our president, and Dr. Chandra Mohan, our secretary, for their relentless efforts to keep this going and for their confidence on the academic council. On behalf of the advisors of 4 zones and Srajan and me, I thank you very much for being here. And we'll see you a fortnight later with a session on colorectal liver metastasis. That is on 2nd June, 7 p.m. Till then, goodbye and good night.
Thank you, sir.
Thank you, sir.
Thank you. Good night.
Bye.
Bye.